Well, good morning, everyone. I want to start out by thanking the IOM for inviting me here. This is a great opportunity. And I also wanted to again reiterate my thanks to all the staff behind the scenes who put this all together. This was an incredible production to organize, so there's a lot of unheralded people in the background. I have the challenge of talking about 15 years of research in 15 minutes. So I'm going to blaze through this like 100 miles an hour with my hair on fire. And when I'm done, I'm going to be exhausted, and you're going to be exhausted. So I'm going to be sort of superficial in some regards. Hopefully, I'll pique your curiosity about some specific issues that we can follow up on in the discussion time. What I'm going to talk about is a 15-year initiative in Pennsylvania in the United States to scale up evidence-based programs. There's been a lot of discussion about trying to define what evidence means, about doing randomized trials and other alternative designs to demonstrate the efficacy or effectiveness of specific interventions, about creating lists. But that is not the goal of what we're trying to do. Lists don't make children better. Lists don't improve the social determinants of health in communities. What our ultimate goal is to get to population level improvements in public health, and that can only happen at scale, right? We won't, if we identify the best, most effective, specific intervention, we'll never be able to send enough people through that intervention to get to achieve population level public health. What we want to do is make whole communities, whole states, whole countries better. So that's the lofty goal of what we're trying to do in Pennsylvania. Again, this is 15 years of research, so lots of people involved. Specifically, I want to thank the Pennsylvania Commission on Crime and Delinquency, who has funded the vast majority of this work. So we've heard a lot in the last day and a couple hours about all that we know about preventing youth problems and how to effectively prevent and reduce youth violence, drug use, and other related poor outcomes for kids. We know a lot about the prevalence of the importance of the timing and prevalence of these problems. We've heard a lot about risk and protective factors. I'm going to talk a lot more about that. It's incredibly important that we approach violence as a public health issue instead of solely viewing it as a public safety issue. We know about the fact that these risk and protective factors occur in multiple domains or spheres of influence in individuals' lives: community, family, school, peer, individual. We know that there are we've identified through research multiple pathways, and this is the royal we, all of us, the whole research body. We know that there are multiple pathways to poor outcomes, and we know that there are multiple specific trajectories that we can think about to differentiate different subgroups of people who have different trajectories towards poor or good outcomes. You heard a lot yesterday about the blueprints for violence. I think I apologize. I apologize to Tony. I stepped out of the room during your presentation, so I assume that you mentioned that this was a project funded by the U.S. Department of Justice, the Pennsylvania Commission on Crime and Delinquency, and the Colorado Division for Public Safety back in about 1994. To do a systematic review of over 500 studies to identify specific interventions that had demonstrated effectiveness in reducing or preventing youth violence or related risk and protective factors. So it's important to set that context and to give credit to the U.S. Department of Justice, Office of Justice Programs, for funding that 15 years ago. But it's important to recognize and keep in mind that this was a list of proven effective programs to prevent violence that was published 15 years ago. Similarly, we did a systematic review for the Center for Mental Health Services on programs to prevent mental health disorders in school-age children. So these reviews have been around for a long time. We heard yesterday about crimesolutions.gov. So we've seen this evolution from from these systematic reviews to making that information much more accessible to the general public in ways that are really actionable and usable. This is the crimesolutions.gov website is fantastic for practitioners and policymakers to trawl through these mountains of research to try to get a sense of what works and what doesn't work. The problem, though, is that we've been working for the last probably 20 years under this assumption that, you know, if we build the better mousetrap, the world will beat a path to our door. If we just figure out what works and make it and put that information up there in usable, actionable lists, that all of a sudden everybody will, you know, charge to the table, grab up these effective programs and implement them in the communities, and all the world will be a better place. And I'm going to use an American baseball reference here. You've probably seen the movie Field of Dreams, and that saying in that movie, if you build it, they will come. My friend Jim Emshoff published an article in 2008 where he challenged the if you build it, they will come. He said, if you build it, they may never know about it. They may not understand what it is. They won't know how to get there. They won't think it fits. They'll think they already have it. They'll see it as competition. They'll decide they should build their own. These are all sounding familiar, right? They'll adapt it into something unrecognizable. They'll only use the pieces of it that they like. So that's the one side. There's also there's another part of the end of that continuum. If you build it, sometimes if you build it, they will come and they'll love it, and then they'll want you to make 10 more just like it in the surrounding communities now. So that's an equally difficult challenge. So given that, the questions that keep me up at night are, why aren't the effect sizes that we see in trials often replicated in the real world? Why can't we take out into messy, dirty, real communities these programs that have demonstrated these great outcomes in hothouse, well-controlled studies and see the same kinds of effects? That's an important question. I mean, I think we know lots of the reasons why that occurs, but that's the challenge to address those. Is it really about market penetration and saturation, or is it about tipping points? We've been charging ahead for the last 15 years in Pennsylvania, and I think this is common in a lot of places, under the false idea that the goal is to now that we've identified these effective programs, the goal is to get them out into as many communities as possible. That this saturation approach is going to be, this market penetration approach is going to be what gets us to population level public health improvement. And we went down that road for a while, and I'll show you that. But now I'm starting to rethink that we need a more strategic approach. We need to move from carpet bombing evidence-based programs to strategic laser-guided strikes. And finally, when we're talking about scaling up, when we're talking about getting out of the hothouse of experimental trials and getting out there into real communities, and getting out there in real communities at scale, large numbers of communities, should we be focusing on practitioners, provider organizations, or systems? And the quick answer to that is we need to address all three, and that's not generally the status quo. So we've talked a lot in the last day and this morning about all of the barriers that are preventing us from moving from lists to improve population level public health. We've enumerated all of these, and they go from the very specific issues of maintaining high quality implementation, the challenges of sustainability that both Julie and Kathy talked about, to these larger systemic issues of how do we get multiple systems. If we know that the underlying risk and protective factors that represent the social determinants of health cut across the system silos of justice and education and welfare and public health, if we know that those underlying risk and protective factors cut across those system silos, how do we work across system silos instead of working in specific silos? So we need to move from prevention science. We've been pretty good at the prevention science part. That's why we're here talking about all this evidence that we have. We've been pretty good at moving from or developing the science of prevention, but what we need to move to now is the service of prevention. We need to think about, issues like providing technical assistance, setting and collecting performance measures, monitoring the quality of program implementation, and ultimately assessing population-level public health. Spoiler alert, I'm going to jump to the end of the story and give away the punchline here. I'm in the middle of my presentation, but I'm going to talk about the outcomes that we've seen in Pennsylvania, because I want to hook you, and I want you to know that what I'm going to talk about is actually relevant. This was Pennsylvania's footprint of evidence-based programs in 1999 when we started this work. This is our footprint of evidence-based programs today in 2013. We, as Jim mentioned in my introduction, we've got over 200 replications of the blueprint programs in Pennsylvania since 1998. 200 replications of that very small list of proven effective programs that you heard described on the panel yesterday as one of the highest standards for demonstrating evidence of effectiveness. You heard Pat Tolan talk about the very high standard that Blueprint set for something being called an evidence-based program. So we've done a pretty good job with saturation and market penetration. Again, this is the menu of evidence-based programs that we're talking about in this project. This is the usual cast of characters. It's worth noting, though, that if you're familiar with the Blueprints list, this is a very diverse set of programs. It goes from nurse-family partnership, working with mothers and little babies, to multisystemic therapy, working with violent 18-year-olds who are literally on the verge of going into deep-end secure incarceration. So it's programs that happen in families. It's programs that happen out in communities like Big Brothers, Big Sisters mentoring. It's programs that happen in schools like life skills training and promoting alternative thinking strategies. So it's a diverse set of programs, and that in and of itself creates a challenge for going to scale, because we have to develop expertise and capacity behind some very diverse programs that work in very diverse contexts. After we rolled out these 200 replications, we measured the population level impact. We started with a cross-sectional quasi-experimental study of 98,000 students in 147 communities. We used propensity score and matching to minimize the minimize the potential of selection bias, because this was a quasi-experimental study. We found that youth in the communities that were implementing these programs reported lower rates of risk factors, substance abuse and delinquency, and higher levels of protective factors than youth in similar demographically similar Pennsylvania communities. We found the results were 7 times as many as we would expect by chance. And this is based solely on a sort of community efficacy building model called Communities That Care, that I'm going to talk about in a minute. When we drilled down specifically to the communities that were using these evidence-based programs off the Blueprints list, the difference was 14 times as much as we would expect by chance alone. Similarly, we did a 5-year longitudinal study where we tracked the developmental trajectory of classroom cohorts of kids, 419 classroom cohorts of kids in communities that were implementing this model versus versus classroom cohorts of kids in similar Pennsylvania communities where this model wasn't being implemented. And what you see here is the relative difference in the developmental trajectory of the average classroom cohort of kids. 11% lower rate of delinquency, 11% less self-reported negative peer influence, 16% better self-reported school engagement, and 33% better academic achievement. That's important because this was a crime prevention. This was a youth violence prevention initiative funded by the State Crime Commission, and the biggest outcome we saw was on academic achievement and school engagement. Why? Because we weren't focusing on crime or violence. We were focusing on the underlying risk and protective factors that are also related to other things like drug use and school engagement and academic achievement. We looked at the impact on the system, on the kids that were going into the juvenile justice system itself, and here you see the difference in out-of-home placement rates of kids in the juvenile justice system between counties that adopted these evidence-based programs compared to counties that didn't adopt the evidence-based programs. In 2010, this had grown to a 3% difference in the rate per 100 youth in the juvenile justice system who were placed in out-of-home care, in congregate delinquent correction centers. A 3% difference in Pennsylvania is equivalent to $3 million. And the best punchline of all, this is breaking news. Last week, the governor announced that he was closing a 100-bed juvenile secure correctional facility in Pennsylvania and taking the $10 million saved from that closing and reinvesting it back into evidence-based prevention, these blueprint programs, evidence-based prevention and intervention programs. There's been a lot of talk about justice reinvestment, about shifting the resources from deep-end incarceration to primary and secondary prevention, and this is that idea actualized. How we did this, it's really important to understand multifinality, the fact that risk factors are associated with a range of poor outcomes, and equifinality, that any given outcome can trace itself back to a number of risk factors. This is really important because we need to shift our idea about surveillance. There was a lot of discussion about surveillance systems yesterday. We need to adopt a much more sophisticated idea of surveillance systems to shift away from collecting data just on the prevalence of behavioral outcomes to the prevalence of the underlying risk and protective factors. And that's what we've done in Pennsylvania using a model called Communities That Care that some of you may be familiar with. In Communities That Care, we collect local epidemiological data on the known risk and protective factors that predispose kids to a host of poor outcomes, and we use that to create a community-specific profile so the community can know for this community, these are the specific risk factors or specific protective factors that we want to focus on, and then use that information on prevalence of risk and protective factors to then go out and seek the programs that they want to implement to target those priorities. That's establishing, if you look at the center of that graphic, that's what is establishing community efficacy. We're growing community efficacy by creating these community coalitions that use this data to make good decisions. This is just a map of all the community prevention coalitions that have been created as a result of this initiative in Pennsylvania. I'm going to skip past this. One of the important lessons that we've learned in doing this work over 15 years is the issue of collaboration. The epicenter that I direct is what we call an intermediary organization. We serve the specific function of connecting policymakers, researchers and program developers, and practitioners. And one of the most important lessons that we've learned is in serving that role of intermediary, think about this Venn diagram. We don't focus on that small piece in the middle where everybody's goals overlap. That's the conventional wisdom. Instead, we recognize the parts of the Venn diagram that don't overlap. We go into the conversation thinking or saying, what do you need to accomplish? What's important to you, policymaker? What's important to you, practitioner? What's important to you, researcher? As an intermediary organization, we have these three specific key functions: building general prevention capacity, building intervention-specific capacity, and facilitating this interaction between those three systems. So just to close, some lessons, observations, and epiphany after 15 years of doing this research or this work. Evidence-based programs are not a panacea, and they rarely fill a void. When we introduce the idea of a program that is effective, it's not going to be dropped into an empty space in a community. It's going to have to displace something else that's already there, almost always. And it's at least going to have to displace somebody's ideas about what works and what causes the problem that they're trying to address. Dissemination of evidence-based programs is a means rather than an end. Let's not confuse, let's not have the tail wagging the dog. Again, the goal is not to get evidence-based programs out into as many places as possible. It's to figure out where they are the best fit to address the most prevalent problems. Scale up is different than dissemination. It's a much more active, engaged process that requires thinking about systems and resources. Dissemination and high-quality implementation are often at odds. They work directly against each other. The more you try to get something out at scale, the harder it is to maintain quality and fidelity of that thing that you're disseminating. So final thoughts, find a small number of things that work and do them very well. Focus on an intentional behavior change model that moves from extrinsic policy regulatory motivators to intrinsic motivators that are related to pursuing excellence through the use of the most effective, most cost-effective interventions. And I'll stop there. Thank you.
Thank you, Brian. Dean?